There we go. So, good afternoon. I am Louie and I will be your moderator for this session. I will be joined again by Charles, who will help ensure a smooth flow for our breakout room, and Adriana will be documenting our session. We are, just to refresh everyone, we are in room one, occupational therapy education. And for this session, we have two presentations. Each of our speakers have 15 minutes to present and 5 minutes for questions and answers. If you wish to ask a question, please type your question through the Q&A box on the right side of your screen. Please use the Q&A box rather than the chat box for your questions. But to ask a live question, please click on the Raise Your Hand tab, which is also on the right side of your screen. We will acknowledge your question and activate your microphone for that purpose. Our first speaker is the Assistant Professor of the Occupational Therapy Department of Gunma University of Health and Welfare. He is engaged in the Education Department of the Occupational Therapy Association and conducts research and analysis on clinical training guidance at clinical training facilities and occupational therapist training schools. His presentation is entitled Effects of Active Learning for Understanding the Occupational Therapy Evaluation Process on Students' Self-Evaluation of Reach in Clinical Skills and Their Results in Clinical Training. Colleagues, it is my honor to introduce Dr. Ryosuke Miyadera of Japan. Dr. Miyadera will begin his presentation with a video that he had shared with us earlier. So give us a few minutes to access the video and we will be going on there.
Hello everyone, it's good to see you all here. My name is Ryosuke Miyadera from Gunma University of Health and Welfare, Department of Occupational Therapy in Japan. All right, I want to begin by discussing some background about this study. In order to connect on-campus education and clinical training, it is necessary to foster clinical learning from within the campus. Classwork was conducted with active learning to understand the occupational therapy (OT) evaluation process by verbalization of the purpose and implementation methods of clinical skills through case studies. We aim to examine the effects of active learning to understand the OT evaluation process on students' self-evaluation of reach in clinical skills and the result of clinical training. Before the intervention, we will introduce the curriculum for the major. It consists of 3 subjects: basic, specialized basic, and specialized. And clinical training occurs in each grade. This active learning class will be conducted before the clinical training of OT evaluation in the 3rd year. The subjects were 34 OT students. In this study, 2 points were verified. Number 1, changes in self-evaluation of clinical skills were analyzed by questionnaire survey. before and after the class. Number two, whether the strength of changes in self-education evaluation could lead to difference in clinical training results was assessed. This is a student's self-evaluation. This is a questionnaire of 6 categories, 84 items in total, related to the knowledge and skills necessary to understand the OT evaluation process. Students can answer each item in 7 ways. The 7 very applicable. 1 not at all. This is an outline of this active learning. Students perform 3 stages. Stage 1, enumerating disabilities, which form disease and life background in the case. Stage 2, planning and conducting OT evaluation from enumerated disabilities. Stage 3, creating and sharing the case overview. And finally, taking oral and written examination. To case via paper or video. Stage 1, enumerating disabilities. Teachers provide basic information about the patient's disease and life background. Example, name, sex, age, disorder, disability. Students enumerate facts from basic information and investigate unknown facts. Additionally, students enumerate the methods of evaluating the facts. Stage 2, planning and conducting OT evaluation. Teachers supported the students by role-playing various job roles in addition to supervising clinical training. Example, patient, a supervisor, and nurse, and doctor. Students verbalized the purpose and methods of the OT assessment tool, and the teacher provided case information whenever appropriate. Oral answer or video presentation. As an example of a student's task, 1. Enumerating OT evaluation methods. 2. Talking to various job holders. 3. Outline the evaluation method and the reason why evaluation data is necessary. 4. Investigate unknown facts. 5. Repeat steps 1 to 4 to obtain a deeper understanding of the case. 6. File the evaluation data in a case note. Stage 3, creating and sharing the case overview. Students created case summaries individually and integrated them in groups. Each group announced the case overview in the class. The result of changes in student self-evaluation. When drafting evaluation plan, conducting evaluation, grasping case overview, methods of reports, and self-evaluation were significantly higher after the class. The result of difference in training performance. The median value of change in the total score of students' self-evaluation before and after the class was 0.5 points. There was also no significant difference in the training performance between the group with strong self-evaluation change and the one with no change. Active learning for understanding the OT evaluation process significantly increased the clinical skill self-evaluation. All students were able to meet the target level in clinical training regardless of the strength of the change in self-evaluation. Simulating OT evaluation process provided an opportunity to realize the need to acquire clinical skills. That's all I have to say. Thank you for your attention.
Thank you very much, Dr. Miyadera, for your presentation. A little bit of change from the original plan. We will be presenting the next speaker now, and then we will save all the questions for later as a plenary, so that we will be able to allow the participants to process the information first and get to have a little bit of thinking about what had just been delivered. So, our second speaker for this afternoon is a senior lecturer of Occupational Therapy Program, Faculty of Health Sciences, University Kebangsaan, Malaysia, that based in Kuala Lumpur, Malaysia. She joined the university in 2005. Prior to this, she worked as an occupational therapist in Cebu Hospital, Sarawak, Malaysia. Given she is interested in hand therapy, she teaches mainly hand and orthopedic related courses in the university, including occupational therapy, physical assessments, and interventions. Her presentation is entitled Occupational Therapy Examination Scores, Internal Examiner versus External Examiner. Colleagues, it is my honor to introduce Dr. Chui of Malaysia, who will be sharing with us a video presentation.
My name is Chui, and I'm from the Occupational Therapy Program, University Kebangsaan Malaysia, UKM. I would like to share our study findings on the comparison of occupational therapy clinical examination scores between the internal examiner and the external examiners. The co-investigators of this study are Dr. Zarani Harun, Janice Jayiku, Muhammad Aminuddin Hassan, Nuis Liana Rohaizat, Nurul Shohaida Asman, and Pei Chi Time. Clinical placement is a spatial arrangement in which a medical or healthcare student is present in a situation or an environment that provides medical, healthcare, or related services to patients. Clinical examinations evaluates the acquisitions of important clinical skills and competencies of students in a clinical placement or related courses, so that the student can deliver safe and effective services to patients in actual clinical settings after the graduation. Different examiners may have different opinions in evaluating a student according to their own perspective and preferences. Score given by the examiners may be determined by several components that can be grouped into four main aspects: examination context, examinee characteristics, examinee and examiner's interaction, and examiner characteristics. And study found that examiners could award the same score to different performances or different score to the same performance. Our OT programs have been approved by the WFOT for 7 years, from 2016 to 2023, and to meet the 1,000 hours of clinical placement, our OT students in the program have to undergo 6 clinical placements from year 2 to year 4. And the 6 clinical placements are: Clinical Placement 1 for physical dysfunction, that focuses on orthopedic and surgery; Clinical Placement 2, Pediatrics; Clinical Placement 3, Psychosocial Dysfunction; Clinical Placement 4, Orientation and Mobility, as well as Physical Dysfunction, that focuses on orthopedic and surgery; Clinical Placement 5, Neurology, Medical and Geriatrics; and lastly, Clinical Competency in various disciplines. And in total, there are about 1,080 hours of clinical placement, and only Clinical Placement 3, 4, 5, and Clinical Competency have clinical or viva examination. Clinical examination contributes 30% for the Clinical Placement 3, 4, and 5, and 40% for clinical competency of the final grade. Therefore, clinical competency is very important. The total durations of each clinical examination is 1 hour and 15 minutes. And during the examination, each student is provided with a patient along with a brief case information. Specifically, 40 minutes is located for the student to carry out OT evaluation and interventions. 25 minutes is allocated for the student to summarize the findings in the form of presentations to the examiners, and 10 minutes for examiners to do the discussion. Student is evaluated by both internal and external examiners during the examination. The internal examiners is usually an academic staff of our program. Therefore, they may focus more on an academic and theoretical aspects of the conditions. The external examiner is the appointed clinical preceptor who supervises the student during the entire clinical placement in a particular discipline. The clinical preceptor is usually an occupational therapist that works in a particular medical facility and owns at least a bachelor degree in OT. So the external examiner may focus more on the clinical aspect of a student performance and the adherence of the standard procedures implemented in that facility. And this arrangement is to ensure a more comprehensive evaluation for both academic and clinical perspective. Our evaluation forms has 3 sections. Section A assesses the student's ability to present the case in terms of medical history, problem identification, short-term goals, and long-term goals. Section A has a total score of 15. Section B assesses student ability in handling the case in terms of conducting OT assessment and interventions. And typically, this involves the ability to answer questions related to anatomy, physiology, psychology, and pathology of the case. This also includes demonstration and suggestions of tool, OT assessment and intervention. Section B has a total score of 50. Section C assesses the overall performance of the student in terms of understanding about the case, ability to answer questions, as well as ethics and confidence. Section C has a total score of 35. Therefore, the entire clinical examination has a total score that can be ranged from 0 to 100. Due to the different assessment cultures between internal and external examiners, we therefore decided to compare the clinical examination score given by the internal examiner and the external examiners. We hypothesized that there is a difference in the examination score between them. This retrospective study was approved by the Research Ethics Committee of UKM. Permission to access the data was given by the head of the Occupational Therapy Program of UKM. Students' Viva score for batches of 2014 and 2015 and 2015-2016 who completed clinical placement 4, that is, physical dysfunction that focuses on orthopedic and surgery, and clinical placement 5, which covered neurology, medicals, and geriatrics, were reviewed. Data analysis was completed using SPSS version 25. Paired t-tests were used to analyze the difference between the score given by the internal examiner and the external examiners. A total of 36 data of 5 male and 31 female students were reviewed. For clinical placement 4, there was only a marginal significant difference, p equals 0.05, in the clinical examination score between the internal examiner and external examiner. And typically, the internal examiner gave on average 68.1x plus minus 10.1, which is slightly lower than the external examiner who gave on average 71.43 plus minus 13.59. And for clinical placement 5, there was no significant difference, p equals 0.44, in the clinical examination score between the internal examiner and the external examiners, in which internal examiners gave an average 70.83 plus minus 12.11 score as compared to the external examiner that gave on average 69.61 plus minus 10.69 score. Our findings noted that the internal examiner and external examiners give consistent score during student clinical examinations, and this could potentially mean that both the internal and external examiners understand the evaluation criteria and adhere to those criteria. They might have a similar expectation on student performance and share similar understanding regarding the student's strengths and weaknesses. By giving both examiners 10 minutes of discussion after the completion of the student case presentation and Q&A session, might also give the examiners an opportunity to develop a consensus in giving a similar score to the students. And this study has a few limitations. We had no data on the number of external examiners involved in the examination sessions. Some medical facilities have more than one external examiners. Because of this, instead of obtaining an actual score from the examiners, we may have received an average score. Comparing an average score with an actual score could reduce the consistency of the result. We also had no data on the education background and clinical experience of each external examiner. Other factors, for example, time of the days and sequence of the student, were also not determined. For example, in terms of examination context, a student being examined at the beginning of the day may tend to be given a higher score. And similar situation may also tend to happen when the student and examiner are culturally matched or previously familiar with each other prior to the examinations. Another limitation is we have a relatively very small data, and for further study, it would be necessary to obtain all the examiner's data on education background and clinical experience so that a more detailed investigation can be carried out to support our findings. These are the references. Thank you very much.
All right. Thank you for both presentations. Um, at this point, we have time for questions. We have about 15-20 minutes of questions and answers. Um, if if in case nobody would have information to clarify, we can actually ask them if they can share with us um, their personal contact details so we can reach out to them and ask for information further about what they have just presented. But I would just like to remind everyone to type in their questions just so we have clarity of the information being requested. All right. There's a question here, Miss Miss Rebecca. I wonder if this is being directed to Dr. Chai. I'm going to try to convey to her the question, but the question reads, may I clarify the difference between the two clinical placement levels discussed? Let's hope she will be able, I will be sending her directly the question. Let's hope she can respond. If there are other questions for the panel, I do have a, if I may though, I know I'm supposed to be moderating, but I am curious, Dr. Miyadera, how do you go about implementing active learning in the current educational landscape? Do you go for face-to-face classes now, or do you stay in remote? Do you do hybrid, and how do you do active learning there?
Thank you very much. Your question. This class of active learning is 2019 years. Yeah. This class is なんだろうな。 Not affected by coronavirus.
So it was not affected by the coronavirus. You
For this year, this class, we are doing it with Zoom. Does that
so
answer
so
your
you
question?
so she yeah, so you were saying that in 2019 it was not yet affected by the coronavirus. Now you are doing it through Zoom. So you're online. You're virtual. You're doing it this
Sorry, I
way?
can't hear you.
Oh, okay. Charles, can you hear me?
Yes, Louis, I can hear you.
Okay. Hang on. But Charles, you can hear me, right? There you go. Yes. And there's feedback. Dr. Miyadera, we got your response. It does answer the question. Thank you. Do we have any other questions? While we're waiting for Dr. Chai to respond to the question. I'm going to write a question for Dr. Miyadera again.
Thank you. Just a moment. Sorry. And now that the infection has subsided, we are doing it face to face.
All right, that answers my question because definitely when it's face to face, it will be seen. Um, there will definitely be active learning there, and there will be easier access to self evaluation to and for the students to measure their clinical skills. Thank you for that information. Okay. Since we are not we are not seeing any further questions, I would enjoin everyone else to join the other room. So if there will be no more, we would like to thank our speakers, and we would like to also The Philippine Academy of Occupational Therapists and Learning Ablers present this certificate of appreciation to Ryosuke Miyadera and Siaw Chui Chai for being an oral presenter during the 7th Asia Pacific Occupational Therapy Congress hosted by the Philippines via AirMeet on November 22nd, 2021. Signed by Roland Lyle Duque and Arcil Rosario Gozon, co-conveners, and Dr. Anthony Gresha, President of the Philippine Academy of Occupational Therapists. Thank you for attending this breakout session. We hope to see you again this afternoon for occupational therapy students. And we enjoin everyone else to join the others in the other breakout rooms. So thank you.
Thank you, Dr. Miyadera.
Thank you very much.
Thank you.